Hello everyone, Leslie Cornwell here, certified nurse midwife with Midwifery Business Consultation. I'm going to do a brief summary of immediate newborn care. The goal of this presentation is to help birth assistants, midwife apprentices, newer midwives with just the basics of newborn care after a birth center or home birth delivery. The objectives of newborn care, why it's so important to watch the babies closely. We want to be able to identify risk factors during the birth and the postpartum period that can affect their transition. So knowing the prenatal history, knowing how far along the mom is in the pregnancy, any clotting factors, presentation of the baby, any concerns with the heartbeat during labor, what color is the amniotic fluid. There's so many things that you can have a conversation about prior to know, is this going to be a high risk or low risk delivery? Typically in a out of hospital setting, we would have transferred if there was any high risk concerns. Most of these babies are going to be low risk and healthy. We are delivering. Our goal is to provide a safe, supportive environment for the baby to be born into. Make sure that all the birth supplies are set up, they're working properly, easy access when birth gets close. The lights are dimmed. We're providing a quiet, comfortable environment. The birth room is warm. The birth tub is the right temperature. We have warm supplies, blankets, towels for the baby when to place on the mom and baby after birth. We assess the baby throughout the transition, so the baby's already out, signs of respiratory, cardiovascular, or temperature concerns. So our goal is just to make sure that baby is keeping the main systems in normal processing. Establishing a good airway, respiratory, so the baby comes out. Most of the time they'll come out crying, but sometimes it takes a few seconds to let out that first good cry. So knowing, is there good heart rate above 100? Is the muscle strong tone nice and strong? Is the baby's chest pinking up after the baby starts to cry? Those are really important things. Promoting breastfeeding and a good latch is also really important for the birth team to have skills with. There's another section of presentation goes into details about breastfeeding support. And then keeping the baby nice and warm. They come out and they're used to their moms keeping them warm. So that's why it's really important to have a room that's warm, put them skin to skin with their mother, a support person in the team, having warm blankets, preventing infections. So making sure we wash our hands, making sure that we're not putting any of the stool from the birth experience on the baby, just keeping things as clean as we can. Care at birth. So the delivery of the baby placed right on the mom's chest. You do it slowly from the water. The assumption is the cord will be long enough. You just don't want to do it fast and aggressive to have any issues with the cord. We're going to immediately, as the midwife, assess the muscle tone, the respiratory efforts, the heart rate, the chest color. There's a lot of things that happen in a midwife's critical thinking skills right after the baby is born. That first minute, there is so much going through her head. She's assessing the bleeding from the vagina, making sure that the cord is okay with the baby, that the baby's skin to skin, that the mother is okay. There's a lot happening in a short amount of time. So the big things I like to stress with the baby is the extremes of, if you don't have good muscle tone, you're not getting any respiratory effort and the baby's blue, don't even bother trying to get the heart rate. It's going to be less than 100. Just immediately grab your ambu bag and give positive pressure ventilation. And that's most of the time, especially if heart tones were really good for the baby right before delivery. They just need something to help open up their alveoli and transition. If the muscle tone is good, the baby's alert, looking around, the heart rate's above 100, but you haven't immediately got a respiratory effort, I have the mom talk, and that carbon dioxide breathing on the baby and that cooler air on the cheeks tends to make the baby cry, but I don't make it a really aggressive stimulation in trying to get the baby to cry if everything else looks good on the assessment. Respiratory effort may be slightly more delayed, and APGAR scores are slightly lower for water births. That is common just because the baby in a typical land birth would be coming out where its head is exposed to the air immediately, and those trigeminal nerves in the cheek are what makes the baby start to cry. So with a water birth, they don't get those cheeks exposed until they've actually been out of their mother for a little bit, and into the air out of the water. So it's just a little more delayed, and that's okay. As soon as the baby comes out, you just put them on the mother's chest, keep them warm. You'll need a warm, firm surface if you're doing that rare resuscitation, but most of the time they can just go skin to skin held by their mothers. APGAR score, which is used, not so much the 1 minute indicator, but the 5 minute, has to do with long-term oxygenation and outcomes neurologically for the baby. So most normal healthy babies will get an 8 at 1 minute and a 9 at 5 minute, or they'll get a 9 out of 10. But the 1 minute, if it's lower, we're not as stressed about, as long as the 5 minute is 7 and above. A lot of times people have the illusion that an APGAR score determines resuscitations, and it's actually the opposite. You're doing your interventions, your assessments. So an APGAR score is telling how well your resuscitation is going. Are you getting good circulation? Are you getting the airway optimized so that the baby is starting to get good muscle tone, starting to cry, starting to get a good heart rate again? So usually the midwife will do that score. Adjustments to extrauterine life. The big things you focus on are the color, the temperature, the respiratory effort, the circulation. So the color, the first half hour, even the first few hours, we don't get stressed at all about the hands and feet being blue. It's the chest. You don't want the lips blue. You don't want the chest blue. You want a good pink chest. And good capillary refill. So just putting a little bit of pressure on the chest skin, and the color should fill back into that white area in less than 3 seconds. It could take a couple days for a good circulatory system to be present. So the hands and feet, I tell families it's okay, especially if that little leg was kinked from an awkward position of breastfeeding. It'll be a little blue. That's okay. It's the chest that's the most important. Temperature, usually we want in general just 97 to 99. The baby will be slightly cooler when it comes out just because it's not used to holding its own body temperature. But a lot of times I don't stress if the temperature is above 99 as far as an infection. It's usually the baby's getting overheated. With the temperature being a little lower, you want to make sure the baby's nice and warm, getting good skin to skin with the mother, but a lot of times low blood sugar can cause the temperature to be a little bit lower. So making sure the baby has nursed recently, getting some sugar, water, getting some calories in to help with that. Checking the vital signs on a baby initially after birth, and then every 30 minutes the first 2 hours. If you're at a birth center, after that first 2 hour mark, you're going to check vital signs every 4 hours till the baby and mom goes home. And just making assumptions, you document all the care that you're doing. The heart rate on the baby is usually a little bit higher when they first come out, especially if they're screaming and a little stressed out. Tends to be more that 160s, 170s, even 180 for a little bit. But typically it's 110 to 160 is the normal transition for a baby. If it's below 100, I don't stress as much lower than 110 to 100, but that 100 and under, there's something else going on with the baby and you need to figure out. And usually if you have a heart rate under 100, you're having other issues with breathing and muscle tone, and there's something more going on with the baby's cardiovascular system. Respiratory outfit. Some babies will cry immediately when they're born. I've had a couple times where the baby's head is out and the baby's starting to cry before the rest of the body. It may take a little bit, up to 10, 20, 30 seconds for the first breath, as long as all the other assessment pieces are normal. I don't super stress about getting the baby to cry. If they're looking around, they've got great muscle tone, they just don't know they're out yet. So let's be patient with the babies and have the mothers talk to them. The breathing pattern can be a little irregular for the first few days. Breathe, a little bit of pause. And so educating the families about that is really important. So when the midwife and the birth team is gone, the families know what's normal, that good postpartum education. So typically breaths are 40 to 60 per minute. The golden hour, which is more used in a hospital setting, but it's promoting all these really important set of evidence-based practices that help with physiological stabilization. So long story short, it's just helping to get the mom and baby's bond stronger. In any other mammal, if you take the baby away right after birth, the mom will not accept it back. There's so many studies that show if you separate a mom and a baby, the mom has long-term bonding and responsibility challenges towards her baby just because that connection isn't as strong. So being respectful of that golden hour, delaying cord clamping, which is most midwives do, immediate skin to skin with a baby exclusively the first hour. You can do a lot of your assessment on the mother, the basic things, and then leave your full newborn assessment once the mother's ready to get up and take a shower, go take a bath, go to the bathroom, those kind of things. Then you can do your newborn assessment. Delay any urgent, non-urgent tasks the first 60 minutes and then get breastfeeding going. There's a high amount of colostrum that first hour that's really important to get into the baby and help with mom's bleeding and help with baby's transition. A lot of this, that good amount of colostrum you get will help affect the circulatory system for keeping the baby nice and warm and making sure that the temperature stays up, improves the mom and baby's bonding. The baby's less stressed, the mom's less stressed. If you implement these, there's a lot of studies showing the long-term effects of supporting breastfeeding will be increased by doing the golden hour. So this is a great resource book for an initial newborn assessment. I know that birth assistants aren't usually doing the newborn assessment, but I think it's important to at least understand the basics. If you're a midwife apprentice, or if you're a newer midwife, it's really important to know a head-to-toe assessment on the baby. What are things that are normal and not normal? I'm not going to go into details on a newborn assessment. There is a handout attached to this course. You can also download to give what are the typical things you're looking for on a baby. I just want to stress the big overall things. A focus assessment is done immediately after the baby is born, the heart, lungs, muscle tone, alertness, and then there's a detailed assessment done after the baby is nursed, after that golden hour, and the mom is ready for the full assessment. A Ballard score more has to do with gestational age. We are assuming this baby is 40 weeks, 38 weeks, 42 weeks based on our prenatal history. So it's nice to confirm based on the baby's weight, the creases, the specific attributes that you're assessing to determine how much vernix there is. Is the baby closer to 38 weeks, 42 weeks, those kind of things. Listening closely during transition to the heart and lungs, making sure that there's no irregularity. Even if there's a little bit of irregularity in the heart rate, I just put a note of it and it'll usually self-resolve the next couple days as long as the rest of the assessment looks good. Start at the head and then just slowly work your way down. You're looking for anomalies, you're looking for areas of concern that are going to affect the baby's well-being. I mean, finding an extra finger and toe isn't going to affect the well-being. It's more just noting. Finding a Mongolian spot is nice to know. Just so those birthmarks are documented from initially, especially with Child Protective Services. As the kids get older, it's nice to have a baseline documentation of the skin and any little slight variations that the baby can have. So before a midwife team leaves the home or the baby gets discharged from the birth center, it's really important to do a good final newborn assessment. It doesn't have to be as detailed as the initial, but you want to make sure that nothing has changed that makes the baby not a good candidate to have no other healthcare providers present watching the baby. Make sure that the postpartum education is given to the mother and the support team about what's normal and what's concerning to watch for in the baby the next couple days. If the midwife is doing the newborn care that first month of life, making sure that the newborn home visit is scheduled for the next day, around 24 hours. There's a lot of state important screenings to be done and a lot of transition things to assess for at that point. If the midwife is not going to be doing the follow-up care, just make sure the newborn care provider is given records, given a report. The next appointment is help coordinated to be scheduled. So just really stressing with newborn care, we have two people we're taking care of after a birth. We're taking care of a mom, we're taking care of a baby, and there is so many transitionary things happening in that baby in a short amount of time, going from inside, their whole entire circulatory system is being reshifted from not using their lungs into their valves in their heart, and their whole circulatory system not using their umbilical cord for blood anymore once it's clamped. It's an impressive process that our babies go through. And so most of the time it goes normal and healthy, but we really want to know what are the things to watch for and the warning signs to make sure we transfer appropriately, and that we're reassuring the mothers and the families that this is normal. Look forward to seeing you at more videos. Thank you.